This is chapter 43 out of your Lewis textbook, Nursing Management of the Patient with a Lower GI Problem. So diarrhea, that is defined as the passage of these 3 loose stools or liquid stools in one day. It can be acute or chronic. Chronic is where it lasts longer than 4 weeks. Diarrhea can be infectious and non-infectious. Some examples of infectious would be like a C. diff infection. Severe diarrhea is actually pretty serious because it can cause severe dehydration and like electrolyte disturbances. So diagnostic studies, they may take a stool culture just to test to see if it's an infectious agent that's causing the diarrhea. They'll do like an electrolyte panel. And treatment is going to depend on the cause. So again, usually the infectious disease are like C. diff is given. They'll treat it with like a flagell, or you'll hear it often called metronidazole, and like a vancomycin. If it's a non-infectious agent, usually they'll give like Gatorade or Pedialyte to reestablish those electrolytes. Non-infectious, they'll give like an anti-diarrheal, so like a Lamodal or Imodium. But if it's an infectious agent or diarrhea caused by like an inflammatory bowel disease, they can't give antidiarrheals, are contraindicated because the patient could develop a condition called toxic megacolon, where the colon will dilate. And make sure that the patient knows if they start taking antidiarrheal drugs that they can't really be on it long term. So again, make sure that you are treating any dehydration. If they're severely dehydrated, they'll need to be hooked up to an IV. Again, with the infectious process, like C. diff, make sure that you're putting the patient in isolation and really cleaning anything that comes in contact with the patient. So fecal incontinence, this is an involuntary passage of stools. It can be caused by really a whole lot of things: the aging process, childbirth, menopause. It could be constipation, diarrhea can kind of bring that on. Diagnostics, they're just going to do like a rectal examination. They could do like an abdominal x-ray. And treatment's going to be caused from the underlying cause. So if it's a constipation, maybe they'll give them like laxatives. They'll tell them to avoid foods like like spicy foods, because it could cause diarrhea and cause rectal irritation. Again, if it's diarrhea that's non-infectious, they can use an anti-diarrheal. We talked about Imodium. They'll prescribe like Kegel exercises to help strengthen that pelvic floor muscle. And if it's severe enough, they could do surgery if everything else hasn't really worked. So collaborative care, make sure that the patient, keep them comfortable, and, it's kind of an embarrassing thing. So potential nursing diagnosis: bowel incontinence, self-care deficit. You're going to want to help the patient maintain maximum function of their sphincter. Make sure that good skincare is being done for these patients. Constipation. This is when there's a decrease in frequency of bowel movements, it varies from individual to individual what's normal. It's normal for some people not to have a bowel movement every day, whereas some people might have bowel movements 1 or 2 times a day. So the common causes of constipation is really insufficient fluids and dietary fiber. Sometimes other medications or diseases can cause constipation. So the clinical manifestations, the stool is going to be dry, hard, difficult to pass. They might have some bloating and some abdominal pain. Diagnostics is going to be through history and physical. So collaborative care, they can give enemas, stool softeners, milk of mag, magnesium citrate that are going to help get things going right away. Make sure that you're educating the patient about their diet, having a diet high in fiber. Fiber is found in like fruits and vegetables and grains. So really encourage those. Encourage enough fluid, but keep in mind like the other diseases that have fluid restrictions, like an acute renal disease or CHF. Make sure that the patient is still following by those recommendations from their physician. So nursing assessment and diagnoses, that could be constipation. And again, you want the patient to increase their dietary fiber and fluids, increase physical activity, because that's going to get the bowels going. And you want them to not have any complications such as hemorrhoids. So acute abdominal pain. Oftentimes this is associated with like a tissue injury, like damage to abdominal or pelvic organs, blood vessels. So the clinical manifestations, the patient's going to have a lot of pain. They might have some nausea, vomiting. They could have diarrhea, constipation with it, fatigue, fever. Diagnostic studies. So they'll do a complete history and physical. They'll ask the patient to describe the pain, because if they have pain before they vomit or after they vomit, will kind of give the physician an idea of what's really causing the problem. You can look at the patient's positioning. They'll do like a CBC, a UA, abdominal x-ray, CT scan. If it's a woman, they'll do a pregnancy test. So, collaborative care for this patient. So right away, emergency management. You want to identify and treat the cause. They'll use some sort of pain medication. Right away, the physician will have you start an IV, usually give like a LR bolus. Nursing assessment. They're again getting those IV fluids going, taking vital signs, if watching like for an elevated temperature, because that can indicate infection. Watch to make sure the pain's not spreading. The physician might order like an NG tube. Nursing diagnoses: acute pain, risk for fluid volume deficit, imbalanced nutrition. So if they need any surgery, make sure that you're educating the patient. Post-op care is monitoring any incisions. Again, an NG tube might be indicated. Usually the orders are for like a low intermittent suction. But remember to monitor the patient, because a complication of an NG tube can be metabolic acidosis. Really monitor and look at the emesis to make sure that you're not identifying any blood. It could be bright red blood or like a coffee ground emesis, where it really literally looks kind of like coffee grounds, and that indicates a bleed. And then making sure that you're instructing the patient not to lift anything 4 to 6 weeks after surgery, and then notify the provider if they have a fever, vomiting, pain, or weight loss, or signs and symptoms of infection. So chronic abdominal pain, these are usually from like peptic ulcer disease or irritable bowel syndrome. Diagnostics is going to be through like an H&P. They might do CT scan, MRI, barium study, endoscopy. So irritable bowel syndrome. This is a disorder where they'll have intermittent and recurrent abdominal pain with stool irregularities. So they'll have like diarrhea one day, then constipation after that, then back to diarrhea. The cause really isn't known, but treatment is aimed at dietary, figuring out the cause. Like some patients will have IBS with like low fiber intake, so they'll need to increase their fiber, but increase it slowly so the patient doesn't get like bloating, and find out what foods cause the extra gas or diarrhea. Like some people have like sensitivities to like they're lactose intolerant, or so probiotics are helpful because those help with some of the symptoms. Imodium, they might give for patients with when they have the diarrhea. They might do like a cognitive behavioral therapy and stress management techniques, because sometimes patients can have IBS from stress. So abdominal trauma. This is injuries to the abdominal area. Most common causes are motor vehicle accidents. Clinical manifestations, you might see other fractures. The patient will have like guarding of their abdomen. They might have some distension and it'll feel really firm. You might see like some bruisings or abrasions. They'll have some really bad abdominal pain. They might be vomiting blood. They might be urinating blood. And then they might have what we call Cullen's sign. And this is where around the umbilicus there'll be areas of some bruising or ecchymosis. And Gray Turner sign is where they have some bruising on the flank. So diagnostic studies, they'll do a UA, they'll do a CBC, they'll do ABGs, an electrolyte panel. They might need to do a type and cross match if they think that the patient might need a blood transfusion. They'll do an abdominal ultrasound, CT. They might do a peritoneal lavage. So management, always your ABCs, you're going to want to prevent hypovolemic shock. So the patient's going to get an IV put in. They're going to have probably some sort of fluid bolus, especially if they're hypotensive. They'll do put in an NG tube. They might need surgery. So appendicitis. This is an inflammation of the appendix. That's a little organ that extends from the inferior part of the cecum. It's not really, the organ really isn't needed. The most common causes of appendicitis is where there'll be an obstruction from fecal matter that will accumulate there and it'll become infected. This is very painful. They're going to have anorexia, nausea, vomiting, again, tons of pain. There is a place called McBurney's Point, and it's located between the umbilicus and right iliac crest. So they'll have a lot of pain there and rebound tenderness. So like when the doctor will be doing some deep palpation, he pushes in, the pain will be alleviated, but then when he releases, that pain will come back. The patient really does not want to move. They'll have a lot of just a lot of pain. They might have a low-grade fever. So this shows where the appendix is at. So diagnostic studies, they'll do a CBC. The patient might have an elevated white blood cell count. They'll do like a CT scan or an ultrasound. They'll start antibiotic therapy right away, and then getting the patient ready for surgery. These days they usually do like a laparoscopic surgery, so the incisions aren't very big. The patient will have to be NPO. They'll put like a little ice bag on the right lower quadrant. Do not use heat because heat will cause the appendix to rupture, because remember that heat's going to get more blood flow there, and again, post-op management, you're going to monitor the signs and symptoms of infection, signs and symptoms of peritonitis. Usually the patient will be discharged the same day or the next day after the surgery, and the patient should not lift anything for 2 to 3 weeks. So peritonitis, that's inflammation to the peritoneum. There's tons of things that can cause it. Cirrhosis, appendicitis, bowel disorders, pancreatitis. So clinical manifestations, they're going to have a lot of abdominal pain, the rebound tenderness like we talked about with appendicitis. They'll have some spasms. The patient might take just shallow respirations because any movement really causes a lot of pain. They might have some nausea, vomiting, abdominal distension, tachycardia, fever. Diagnostics, they'll do CBC. They'll have an elevated white blood cell count. They might, if there's some peritoneal fluid, they'll aspirate it and they'll just do like a culture. They might do an abdominal x-ray, ultrasound. So for collaborative care, you want to manage that patient's pain. If they've had a lot of vomiting, they need IV fluids, they'll need antibiotics, they might need surgery, they might be given like an antiemetic like Zofran or Reglan. So post-op, again, monitoring incision if there's any drains. So gastroenteritis, that's an inflammation of the mucosa of the stomach and small intestine. The patient will have some nausea, vomiting, diarrhea. They might have some blood in their diarrhea. So treatment is to give them fluids for the fluid loss and identify the agent. They might need an antibiotic. Inflammatory bowel disease. There's a couple different kinds, Crohn's and ulcerative colitis, and it's based on the clinical symptoms. These are autoimmune diseases. So again, the difference, like Crohn's disease will have areas, some areas of the colon will be affected while others are not. So you can have a patch of affected area followed by one that's not. Whereas ulcerative colitis, once there's a spot, it'll affect the whole area. So clinical manifestations, bloody stools, they'll have loose stools, abdominal pain, fever, fatigue. They'll have a lot of weight loss from the malabsorption. With Crohn's disease, they might have some rectal bleeding, but they don't really have a whole lot of rectal bleeding with ulcerative colitis. So diagnostics, they'll do CBC, the patient will have an elevated white blood cell count. They'll do electrolyte panel. They do a colonoscopy, do a barium enema. They might do a biopsy. So potential complications of IBDs are like arthritis, skin lesions, again, that weight loss. With patients with ulcerative colitis, they might get that toxic megalocolon. And these patients, it's recommended that they have a colonoscopy pretty frequently. So drug therapy, sulfasalazine is a medication you'll see oftentimes in practice, and it suppresses that inflammation to the large intestine. For side effects for this medication, it can cause like an orange color of the urine in the skin, and then you want to tell the patient to avoid prolonged exposure to sunlight. They might do immunosuppressants like methotrexate, Humira, So surgical therapy, patients with Crohn's, the surgical therapy will reduce remissions, but reoccurrence rates are still high. They'll do, for ulcerative colitis, they'll do a total colectomy with an ileoanal reservoir. And so usually the patient then will have a temporary ileostomy, and then so it'll be a combination of the two surgeries, and that'll be 8 to 12 weeks apart. This table 4318 on page 1027 is just the indications for surgical therapy with IBD. This is just a diagram of how the surgery, suture lines. So post-op care, again, monitoring the stoma, observing for signs and symptoms of infection. You're going to want to teach the patient Kegel exercises. Nutritional therapy, the patient will need to be put on like vitamins. They might need some cholestyramine packets, folic acid. If the patient's taking a corticosteroid with their other immunosuppressants, they'll need a calcium supplement. The patient needs to stop smoking. They might need parenteral nutrition. They'll need some iron, some potassium maybe. Again, making sure that you're monitoring fluid and electrolytes, signs and symptoms of infection, teaching the patients to take short periods of rest so they don't get so fatigued. Just with geriatrics, it's just important to keep in mind that they're at higher risk for dehydration. So, bowel obstruction or intestinal obstruction, this is when intestinal contents can't pass through the GI tract. It can be a partial or complete. So there's mechanical and non-mechanical. Mechanical, it would be like a hernia or a tumor. A non-mechanical is from like a neuromuscular or vascular disorder. A paralytic ileus is where the patient won't have any bowel stones because there's no peristalsis going on. So, etiology, patient will have some distension and retention. They can get an intestinal strangulation, which is an emergency because it causes bowel necrosis. Some obstructions, it could be relieved without surgery. Some have to have surgery. The clinical manifestations, they'll have abdominal pain, distension, they won't be able to pass gas, they'll have like hypoactive or absent bowel sounds, you may have some vomiting, you may notice that the vomit smells like feces. You might notice that the patient has like a high-pitched bowel sounds. Diagnostics are through CT scans, X-rays. They'll do CBC and electrolyte panel. So collaborative care, again, if the bowel is strangulated, they'll do emergency surgery. The patient will need to be NPO, insert an NG tube, they'll give LRs. If the obstruction doesn't improve within 24 hours, they might do surgery. Surgery will involve a resection of the obstruction. So, collaborative care, again, you want to recognize any signs of like hypovolemic shock or bowel strangulation. You're going to monitor their pain, do a GI assessment. They'll need strychnine, so you might put in like a catheter. Nursing diagnosis, acute pain, fluid volume deficit, and balanced nutrition. So our goals are to relieve the pain, relieve the obstruction, and establish normal food and electrolyte balance. So a patient with a high intestinal obstruction is more likely to have metabolic acidosis, or alkalosis, I'm sorry, and a patient with a low obstruction is at greater risk for metabolic acidosis. So, care of the NG tube. So, a lot of times in these patients, you know, I talked about the vomiting and the emesis that smelled like feces. You know, if you can imagine, this is really pretty unpleasant for the patient. So you can use like a mouthwash. You know, just make sure the patient doesn't swallow anything, just to rinse out their mouth. They can brush their teeth. You want to give them like maybe some chapstick for lubricant of their lips. Check the nose for irritation, and then again your MG tube, like checking for patency, checking for placement. Really, they're kind of moving away from, you know, checking for placement with air. pH is actually, you know, after they've done the X-ray verification of placement, pH is really the preferred way to check. So polyps, there is many different types of polyps. It can be benign, it can be malignant. So they'll do, they usually find it with colonoscopy. So if a patient is getting a polyp removed, Watch for any rectal bleeding, fever, abdominal pain, abdominal distension. Just a picture of a polyp. Colorectal cancer. It's more common in men than women. Mortality rates are the highest amongst African Americans. So they found this to be hereditary, a combination of like hereditary lifestyle factors. So patients that are obese, that smoke, that drink, and eat a lot of processed foods or a lot of red meat are at the highest risk. So the clinical manifestations, so they'll have cramping, they might have some anemia, blood in their stool, weakness, fatigue, they might have some weight loss, alternation of constipation, diarrhea, they might have like ribbon-like stools. Diagnostic studies, so we'll do colonoscopy, they can do a fecal occult blood test, a fecal immunochemical test, if you have a family history of it, you should get a colonoscopy every 5 years beginning at age 40. If they find something, they'll use a staging system, which is like the tumor, the node, if it's metastasized. We'll have to do surgery. So they'll do like a resection of the tumor. They might need to remove the lymph nodes and then drain the area where the cancer's at. Before any surgery, they'll need to take the Go Lightly, and that they have to drink. They have to drink a big, I believe it's a gallon of solution that will, it will make them have bowel movements and pass everything out of their colon. They might need chemotherapy or radiation. So, nursing assessments, finding out if there's any other cancers in the family, their functional health pattern, nursing diagnoses, acute pain, diarrhea, constipation, fear, ineffective coping. Health promotion, again, you want to encourage screening, early screening. So pre-op care, you want to do a lot of education. They might need an antibiotic, they'll need fluids. Post-op care, they'll have an open wound, they'll have some drains, so make sure that you're doing wound care, monitoring for signs and symptoms of infection, managing those drains. Talk to the patient about sexual dysfunction. The patient might have a colostomy, so you need to teach them care of the colostomy. So, an ostomy, is a surgical procedure where it allows, the intestinal contents to come through an opening of the skin, and that's called a stoma. They can be temporary or permanent. So there's a couple different kinds. They can have like an ileostomy. There's an instoma. And they'll make what they call Hartman's pouch. If they have to remove the distal bowel, the stoma will be permanent. But otherwise, if it's not, it might be temporary. There's a loop stoma, and this is where they bring a loop of the bowel to the abdominal surface to provide the diversion. This kind is temporary. Then there's the double barrel. And this is where both the proximal and distal ends. And these will be two separate stomas. Again, temporary. It could be an ilioanal reservoir or a cock pouch. The cock pouch is a continent ileostomy. And the ilioanal reservoir, they'll have to have a total colectomy done, and then they'll have that formation of the ilio reservoir. So pre-op care, again, education, because this is really scary. It's going to alter the patient's appearance. Do some education before surgery about management of the ostomy. Post-op care, again, looking at the stoma. The stoma should be like pink or beefy red in color. If it's dusky blue, there's some ischemia going on, and if it's like a brown-black color, there's some necrosis. So make sure you're looking at the stoma every 4 hours. There should be a little bit of swelling 2 to 3 weeks after the surgery. So initially their pouch, and then the size might be larger, but after a couple weeks, remeasure again, and you'll notice that the patient will need a smaller size. So again, good skin care is very important with an ostomy. And again, this is pretty embarrassing for the patient. So there's different measures you can use. You're gonna want to teach the patient how to burp the bag, get that excessive gas out, but a lot of patients are pretty offended by that smell, and so you can tell the patient there's little drops they can put in their appliance to help the smell. I encourage my patients to carry around like little wet wipes with them. They might have to do a colostomy irrigation to stimulate emptying of the colon. Just educate the patient that if they irrigate regularly, they should have more bags available because they might get diarrhea from when they eat. Ileostomy care. So again, it's pretty similar as far as like You know, caring for the stoma, it's pretty similar. So again, doing that teaching on skincare. The stools are going to be looser, so they might want like a low fiber diet initially. They'll tell them to avoid like popcorn, stuff with seeds in it. So again, adaptation to an ostomy. I mean, it's, for a lot of patients, it's pretty tragic because, you know, it's an alteration to their appearance. You want to educate the patient to avoid heavy lifting for 6 to 8 weeks. They can take the appliance off in the shower. The water's not going to affect the stoma. Talk to them about sex, because it, you know, really, their sex life doesn't have to be altered because of the stoma. Again, they might feel uncomfortable because their partner will be able to see it. Diverticulitis. So these are little dilations or little pouches of the mucosa in the colon that become inflamed and irritated. Really, the cause is unknown. The clinical manifestations, some people don't even have symptoms at all. But if they do have symptoms, it might be some abdominal pain, just bloating. They'll complain of excessive flatulence. So complications can be obstruction, peritonitis, diagnostic. We'll do H&P, abdominal, X-ray. They could do CT scan. So nursing management, encourage a high fiber diet, decrease in fat, weight reduction, kind of let the colon rest. The patient might be put on oral antibiotics and a clear liquid diet for a while. The patient might need surgery. They can't get it under control. Hernias. So there's a few different types. There's an inguinal hernia. It's the most common type. And this is where there'll be a hernia where there's a weakness in the abdominal wall, where the spermatic cord is in men and where the round ligament is in women. And they'll have, you know, just kind of a little protrusion. A femoral is where there's a protrusion through the femoral ring and it looks like a bulge. This one can become strangulated easier, and it occurs more often in women. There can be ventral or incisional hernias, and that's a weakness in the abdominal wall at the site of where they've had an incision. So the clinical manifestations, there may be some pain. If it becomes strangulated, they'll have severe pain and like symptoms of a bowel obstruction, like they'll have the cramping, the vomiting, abdominal distension. So diagnosis is based on H&P treatment. They'll have to do laparoscopic surgery. Nursing care, you need to watch for any bladder distension. The patient might have, if it's a male, then it has some scrotal edema, so you might want to, put some ice there, elevate their scrotum. Do some deep breathing, but not coughing. If the patient needs to cough or sneeze, give them a little splint. No heavy lifting for 6 to 8 weeks. Malabsorption Syndrome. This is where the body's unable to absorb our nutrients that we need. So there's some sort of interruption caused by like a disease, like we talked about, some of the irritable bowel, we talked about Crohn's, ulcerative colitis. The patient will have weight loss. They might have diarrhea, and that's where the stool is really, really smelly, and it's like almost greasy and bulky. It can be like a yellow color. If it's from lactose intolerance, the patient's not going to have that diarrhea. So they can do endoscopies. They'll take a CBC, electrolytes. Celiac disease, this is autoimmune. It's where the patient can't tolerate wheat, barley, and rye. So they have a gluten sensitivity. So the clinical manifestations will have foul smelling diarrhea, abdominal distension, they'll be bloated. The severity of the symptoms are going to depend on the patient. They'll rule out other diseases. They might do a biopsy. They might just ask the patient to go on a gluten-free diet, and if things improve, that's an indicator. They might draw IgA, do histology studies. Again, they need to have a gluten-free diet, and really, today, you see so many aisles of gluten-free products. It used to be you hardly could find these products, but I think we really need a push towards, kind of diet accommodations for all. So lactase deficiency, this is where the patient does not have a lactase enzyme that breaks down the lactose. So the patient will be lactose intolerant. So they'll have, when they eat something with lactose in it, they'll have bloating, flatulence, they'll have a lot of cramping, abdominal pain, some diarrhea. So treatment, again, try to have a diet without lactose, which to me would be very, very difficult. They can take medications like Lactase if they do have some milk or ice cream or whatever, but they need to take that before the dairy product is ingested. Short bowel syndrome, this is from a surgical resection, or it could be from a congenital defect. There will be a failure to maintain electrolyte balance, nutrient balance. So clinical manifestations, malnutrition, vitamin, mineral deficiencies. They might have the oxalate kidney stones. So your overall goal is to manage fluid and electrolytes. The diet needs to be high in carbs, low in fat. So they can give like anti-diarrheals. They can do an intestinal transplant. GI stromal tumors. This is a pretty rare cancer. The patient will have some bloating, nausea, vomiting. This may be difficult to detect because these symptoms are, as we talked about, pretty much in every GI disorder. But the patient will have to have surgery. They might need some chemotherapy, radiation. Anorectal problems. So hemorrhoids. These are dilated veins. They can be internal or external, but the patient might have you might notice some rectal bleeding, some streaks of blood in their stool. They can be pretty painful. They can be like reddish blue in color. Patient might have some blood clots. Constipation or diarrhea makes the symptoms worse. So diagnostics by visual inspection. For constipation, they might give some stool softeners. They might give they can do like Tux pads, some hydrocortisone cream. They might do the witch hazel or benzocaine to help relieve the discomfort. If the hemorrhoids are severe enough, they'll do surgery. So anal fissures, when there's a crack in the lining of the anal wall, it can be caused by trauma, infection, inflammation. The major symptoms are anal pain and bleeding. And the pain's going to get really bad after the patient has a bowel movement. The patient will feel like they are literally defecating, like it's been described as glass, like broken glass. It's diagnosed through physical exam. Again, the patient will need to take stool softeners to help reduce that pain. Warm sitz bath. They'll do like suppositories with hydrocortisone. And again, if it's severe enough, they might do surgery. Anorectal abscess. This is where there's collections of pus. It's the result of an obstruction. So the patient will have some pain, swelling, foul smelling, drainage, tenderness. They'll have a temp. And they'll use surgical therapy, so they'll get out to drain the abscess. They'll use packing with like petroleum jelly. So you'll have to really teach about wound care because the area will have to be packed daily. Fistula is an abnormal tunneling from the anus or the rectum. It could go to the outside of the skin, the vagina, the buttocks. Oftentimes patients with Crohn's disease have it, but the thing is this can cause infection. So again, surgical therapy is going to have to be done. Pilonidal sinus. This is where there is a small tract underneath the skin between the buttocks and the sacroesophageal area. So it may have several openings. It'll become really irritated, and they could have pilonidal cysts or abscess. It's fine if there's no symptoms of infection, but when it becomes infected, the patient will have a lot of pain and swelling. So then it'll be wound care, antibiotics, sitz baths. And the patient will have to have very good peri care after urinating or defecating.